Okay. Thank you very much, and thank you to GenSpec for inviting me here and making my wife Patrice and I feel so welcome. I want to kind of start with an apology because this is a pretty rough way to start a Sunday morning. Because I'm going to be walking you through some really horrifying things. One of the problems that we've talked about is the lack of clear understanding about what gender affirmation in terms of surgery actually does to people. One of the sort of meretricious things about plastic surgeons is we present our work as if it was like the work of God, that there's no scar, that it's perfectly functional, and all that sort of thing. And the public tends to have that sense of it. If you're driving down the highway and you see a billboard for liposuction, they'll have a picture of a 17-year-old female volleyball player who's never darkened the halls of a plastic surgeon ever, anywhere. So we do that a lot, and so there's a lot of misunderstanding in the public about what it all entails. So today we're going to talk about a detailed examination of the principles of plastic and reconstructive surgery. I bet you didn't expect to get a medical school lecture this morning, but there's some things about what it is to do plastic surgery that you have to understand, and the first and most important thing is the distinction between what is reconstructive surgery and what is cosmetic surgery. We're going to review some of the procedures involved in affirmation surgery. It's not going to be an exhaustive thing, but you're going to get a sense for what affirmation surgery actually entails and what the results actually obtain. We're going to really talk in some detail about the corrupted informed consent process. This is one of the most important things that we have to understand, and the amount of fraud and deceptive practices involved in the transgender treatment industry. If you want a 10-minute synopsis of this, go to the Federal Trade Commission presentations. I normally talk for about an hour, and I squeeze it down into about 10 minutes, and it looks like I'm high on cocaine or something. But it details all of the fraud and misrepresentations that's going on there. And then we're going to finish up with a call to mercy. It is Sunday after all. So gender affirmation surgery is surgery about maleness and femaleness, amen? But long before what we today call gender affirmation surgery has been going on in the aesthetic world. It's fundamental to aesthetic surgery, fundamental to plastic surgery, cosmetic surgery. Aesthetic surgery is what I prefer to call it because it's surgery that aims itself at improving people's subjective life. You know, the aesthetics of a building has an effect on our hearts as we walk around in that building, or a painting or something like that. And certainly when we look at other faces, it has aesthetic effects. So it isn't just cosmesis, it's aesthetic, because aesthetics is a human reality. It's a very important human reality. Truth, beauty, and goodness. Beauty is a very important part of that. So, and how it resides in the subjective life of the person is a very important thing because that's where the distinction between reconstructive surgery and cosmetic surgery begins. Okay, so, por ejemplo, right? Masculine and feminine is really sort of a Gaussian distribution. There are some men who have very masculine faces and other men who have rather feminine-looking faces, and the same can be said about women. And generally, depending on where and when you live, there will be sort of ideals, or you may have an ideal in your mind about what it means to be a man and what a man looks like or what a woman looks like. And so a lot of what plastic surgeons have been doing since way back is to make a man's face look more masculine or make a woman's face look more feminine, depending on the time and place. So this kind of took a change in the world of authentic surgery. And I'm not talking about the crackpot stuff that happened in Germany in the 20s and so on, where utterly incompetent people tried to do impossible surgeries and killed a young man. But this is Sir Harold Gillies. He is one of the luminaries in the world of plastic reconstructive surgery. He made his bones in the First World War. He and his colleagues reconstructing trench warfare injuries, high-velocity missiles hitting soldiers in the faces and the devastation that caused. And he ran an operatory in England reconstructing faces. And for that work, he was knighted, Sir Harold Gillies. But in the interwar years, he reports on a surgical case. It's actually a series of surgeries performed on a woman who wanted to live as a man. So I would call this really the first actual true surgical attempt of affirmation surgery in the service of what has to be understood as a performative identity. right? So in the case of a man who's living as a man who wants to look more like a man, that's different from somebody who wants to live a performative identity, whatever that might be. So it's sort of the beginning of what we have in the medical literature supporting affirmation surgery is what's called single case presentations. Sir Harold Gillies talks about this woman. If you go into the American literature on gender affirmation surgery, what you find is case collections, single surgeons, one or two surgeons, collected cases, reporting on those cases. It's important to keep that in mind because it speaks to what the level of scientific evidence is in support of doing these things to people. So single surgeons, self-selected patients. I mean, that woman found him. He didn't go out looking for a gender-distressed person. That person found him. So that's self-selection bias as an example. So what is reconstructive surgery? This is a very important thing to understand because if you drill into what is presented as gender affirmation surgery, in their documents, in the documents of WPATH, in the testimonies of those in support of gender affirmation surgery, they speak of it as reconstructive surgery. Because when you hear reconstructive surgery, you think, oh my goodness, that's very important surgery, that's very necessary, because you're reconstructing somebody's life. What is reconstructive surgery? Well, it begins by defining a defect. There's a defect, there's a loss, there's a poverty that the person suffers because of an accident, because of combat trauma, because of cancer care, because of in utero accidents, because of genetic accidents, whatever it may be. You can define the defect, missing a finger from the hand, absent palate, whatever it may be, you can define it, you can measure it, you can describe its intended function. You can characterize it in terms of what kind of tissue is needed to reconstruct it. If I'm reconstructing a breast, what I need is fatty tissue that's well supplied with blood. If I'm reconstructing a forearm, I need to import some bone or maybe lengthen some bone, soft tissue covering, nerves. Do they need to be able to feel that part? If I'm reconstructing, say, in their mouth, they need to be able to feel the reconstruction so that they can tell when there's saliva that needs to be swallowed, or so that they don't bite the reconstruction. It's called protective sensation, a very important part of reconstructive surgery. We do this by moving tissue around, right? So if I reconstruct a breast, I might take the tissue from the bottom of the abdomen and put it up on the chest. In order to succeed at that, I have to account for how is it going to live? Where's the blood going to come from? Where's the blood going to go? Does it need sensation? Where's the nerve going to get plugged in? All of that stuff. That's what's sort of collectively called flap surgery. You hear the word flap. Sounds kind of comical, but what it is a defined territory of tissue with a defined blood supply and perhaps nerve supply that I can transpose and successfully attach it to a new blood supply and a new nerve supply. Does that make sense? That's what a flap is. This is kind of what they look like. This is an example of a flap. This is what we'd call the transverse rectus abdominis flap. This is one of the most commonly used flaps in breast reconstruction. It's a known territory of skin that has a named blood supply that I can isolate, I can take it free, or I can keep it attached to its blood supply and rotate it down, say, into the groin. I used a flap very much like this to reconstruct the genital area of a sailor who, she got blown up when the USS Cole was blown up in the Gulf of Aden. One of my patients, so I used a rotational flap. It remains attached to its blood supply in the groin, and I just rotated it down into the pelvis. Or you can take the whole flap free, reconstruct the chest, whatever it may be. That's what a flap is. And the image on the right there, let's see if I do this laser thing right. Yeah. Named blood vessel comes in. It either goes through the fascia right under the flap, or it goes through a muscle and into the skin, whatever. I can take the skin and the blood supply. I can bring the muscle with it if I need it for whatever. So this is what a tissue flap is. This is what's used in gender affirmation surgery, along with everything else that is done. So, okay. Here's the difference, though. Whereas before, here you define the defect and you determine what you need to reconstruct the defect. In the case of gender affirmation surgery, your first step is an intentional mutilation. You have a patient that arrives in the operating room, is going under anesthesia, is whole. That person is whole, fully functional, everything's working, everything's there, and your first move is to mutilate them. I use the word mutilation when I testify in court, and it just puts the ACLU aghast, and they challenge me on it every time, and they go, well, how can you say that? This is a reconstructive operation, mutilation. Mutilation is a defined event, right? That's characterized by the loss, that's a definable loss, that's done either intentionally or accidentally, but there's a loss of a human function, a loss of a human capacity, a loss of an aesthetic unit of the person. You can define the loss. Now you've got a reconstruction to do. You caused it, right? Okay. In the case of genitourinary cross-sex reconstruction, it's in the service of a cosmetic outcome, right? So if I'm doing a reconstruction of a hand, right, there's innumerable functions that a hand serves, right? My reconstruction is primarily aimed at the function that will result. Cosmetic results in hand surgery are not very important for the most part. What's more important is the function that's going to result from the reconstruction, right? We aim for a good cosmetic result, but function trumps everything else. You know, in the case of a facial defect, cosmetic is much more important because there's not a lot of function out here on the cheek, right? Maybe sensation will be important, whatever that may be, but so you can measure the need based on what is the function and what is the aesthetic loss there. But the thing to understand about the genitourinary reconstruction is it begins with a mutilation and it results in a counterfeit. And I use the word counterfeit in court, drives the ACLU nuts, but that's what it is. When you do a phalloplasty for cross-sex presentation patients, you're not creating a functioning penis. You're creating a cylinder of flesh through which urine is conducted. That's what it is. It's basically a urostomy is what it is. It's an elegant urostomy, right? Likewise, when you do the male to female, you're creating a receptive sleeve, but that's not a vagina, and it's not a reproductive organ. It's basically just a wound that's lined with living tissue. Okay. Again, my apologies for doing this to you on a Sunday morning. Okay. This is a radial forearm phalloplasty. Okay? All right. What are we seeing here? I'll put the laser pointer on this side. This is the right forearm of this patient. And what you're seeing here is the drawing, the planning for what's called a radial forearm free flap. What does a free flap mean? That's one of those flaps that you take completely free and you put that tissue somewhere else. In this case, the tissue is coming from the forearm. Why the forearm? Well, because this is relatively thin skin, and a penis has relatively thin skin. It has a named and very robust blood supply, and it has also named nerves that course through this, the antebrachial cutaneous nerve. You can find that in the dissection, and you can use that nerve to make the flap sensate, right? They can feel this counterfeit penis. And what you see here is this flap has been raised. It's now on the back table, and the surgeon has fashioned it into a cylinder of flesh. These hash marks here, this hash mark area is going to meet this hash mark area here, and in closing it, you're making a urethra. And the urethra runs through the entirety of the flap, and then that cylinder urethra is covered by the cylinder of flesh on the outside. These sutures here is the suture closure of the skin edges from the back side, right? So you have a urethra running through this whole thing, and then this little area of skin has become the counterfeit glands, okay? So then this is transposed up onto the groin. Again, the patient's been mutilated first. They've had a vaginectomy. At some point, they've had a oophorectomy and their hysterectomy, right? So you've robbed them of a human capacity, the reproductive capacity. And you're placing this structure on the pelvis. Now, whenever you lift and move tissue around, you compromise its blood supply. When you cut through the skin around the flap, you're cutting off blood flow that skin territory enjoyed before you made the incision. So you're limiting its blood flow down to, in this case, the named radial artery, right? So this has less blood supply even before you transpose it. Then when you fold it, you're challenging blood flow, and it is surely as if you press on the skin of your wrist and it blanches. It's blanching because the blood isn't flowing in the capillaries under the skin, right? So anytime you lift, you turn, you fold, you sew, you're compromising blood flow. And why is that important to understand? Because that's where flaps live or die. And the parts of the flap most likely to die are the parts of the flap furthest from the blood supply. So in the case of the radial forearm flap here, there's the radial artery right there. The part of the skin furthest from its blood supply is around the back side of the arm when they took the flap. That back side of the arm incision is what this closure represents right here. And that closure is laying right on top of this urethra that you've created as well. Why am I exhausting you with these details? Because when you have decreased blood flow, you have impaired wound healing. And impaired wound healing causes wounds to break down. And then things start happening, like the wounds start spitting out suture. The presence of foreign material increases the likelihood of infection. It's a zone of highest tension, the part most likely to die. There's a saying in reconstructive surgery that the part of the flap most needed for the reconstruction is the part most likely to lose its blood supply. Well, that's generally what you see here. So not only do you fold and you spindle and you do all these things to this flesh, but you also have to suspend it. So now you hang it. Now the weight of the flap itself is compromising the blood flow. All right, we're not going to get further down that road, but why is this important? Because it speaks to the most likely complications of an operation such as this. If your wound closure starts to fail, you can develop a chronic wound. If it's failing in the territory of the urethra, then you develop a chronic wound that urine is coming out of. That's called a urinary fistula, right? And that leakage of urine is out of the control of the patient. Urine just starts dribbling out, and you've got a chronic wound, right? And there you are. Now, this is the patient urinating through this construct, and what you see on the far side of the picture is the forearm. This is the donor site, When you lift and you remove that flap, you have to cover the exposed muscles and tendons with skin. What you do is you take a blade and you shave skin off the thigh, typically the lateral thigh. It's called a split thickness skin graft. And you lay that on the donor site, right? So that weird looking skin right there that's all shiny, that's just the superficial layer of skin shaved off the thigh and applied to that wound. So essentially you've got this arm dimension that comes down and then it drops, it steps down. You can see the muscle bellies and tendons underneath it because that's very thin skin. And then it steps back up at the wrist. That's the donor defect. Okay, so you can develop urinary fistulas. In the case of male to female, what you're doing is you're placing a counterfeit vagina construct up into the pelvis. Now you've got suture lines in this counterfeit vagina construct, and that structure is sitting between the bladder on one side and the rectum on the other side. Now when the wound is failing to heal and spitting out sutures, that foreign material can cause communication between the construct, fake vagina, and the rectum. Now you've got feces coming out through the counterfeit vagina in addition to urine. Both of those things are well reported in these constructs. The other problem is that you're placing skin up in the pelvis that doesn't belong up there, right? When you speak about skin, skin is a variety of things, and some skin is meant to be in dark, moist places, and other skin is not, right? Yeah, so for example, the skin of the phallus, when you do what's called an inversion vaginal construct, inversion of the penis, you're taking skin that belongs in the outside world and you're tucking it up into this warm, moist pelvis, and you've got a construct that you can't even examine. It's up in there somewhere, and we hope it's doing well, right? And that skin is not made to be up in a warm, moist environment. So now you've got wound healing issues, and it doesn't want to maintain its dimensions, so you have to constantly dilate that thing. And so now you've got mechanical trauma in addition to a wound that's trying to heal in an environment where it does not belong, and the problems start to abound. The other thing to understand about that operation is that it was the most commonly done male to female genital surgery up until recently. It's changed now that loops of intestine are used to create the counterfeit vagina, because the typical patient has now been on puberty blockers and cross-sex hormones, and they have a poverty of penis tissue. So you can't even do that operation. Okay. How do you even preserve sensation in a thing like this? Well, if I'm doing a reconstructive operation and I have to have nerve supply there for the sake of that construct, I consider it an absolute victory if that construct has what's called protective sensation, right? If they can tell when they're like laying in bed and they're laying on it, right, so that they don't compromise its integrity, that's called protective sensation. They're not sitting on it. They're not catching it in their zipper, or if they do, they remedy the situation immediately because they can feel they got protective sensation. That's not the same thing as erotic sensation, clearly. And when you do this construct, you're typically plugging that nerve, that named nerve, you're plugging it into a nerve of the groin. So now you hopefully have protective sensation, but now when something or someone is touching it, it feels like somebody is lightly touching your groin. It's not genital sensation at all. Whatever erotic sensation is preserved in that operation is preserved by preserving the clitoris at the base of that construct. The problem is you have to dissect the clitoris up out of the way to hang that structure in place. So now you've got the clitoris laying at the base of this counterfeit phallus. And just like with blood supply, anytime you lift and you move tissue around, you compromise sensation. So the best you can hope for is some portion of what was there to begin with. So the typical person who has surgeries like this, if you go online, and I recommend you don't, where people are talking about the results of their genital surgeries, what they'll describe erotic arousability, but their partner is incapable of provoking them. Only they know how to arouse themselves to orgasm. And so basically sex is a form of witnessed masturbation, right? Meanwhile, the public thinks that we're creating fully functional penises, which is obviously not the case. You have a slab of flesh that can conduct urine that hopefully has protective sensation. End of story. Okay, here's an example of the problems, right? Here's a counterfeit phallus using an operation like I just showed you there. And where this arrow is showing you there, right there at the bottom of it, this is what's called a retrograde urethrogram. The radiologist is shooting some contrast up through the urethra to see where it goes. You can see the pelvic bones there, and here's the construct phallus, and there's the catheter going in there. And you can see urine leaking out of that. That's what a urinary fistula looks like. And, they can be healed, but it's a lot of work sometimes. And ostomies are sometimes required, diversion of the urine, diversion of the feces, whatever may be necessary. So let's talk real quickly here about chest masculinization. This is the most commonly done operation in gender affirmation surgery. You take a completely normal female and you amputate her breasts, and you reapply the nipples as full-thickness skin grafts, right? So the breasts are completely removed, liposuction of the chest if necessary, and then the nipples are taken off the amputated breasts, the nipples are put back on as full-thickness skin grafts. That's an example, right? A totally whole, beautiful person has now been mutilated. There's a loss of function. This isn't a benign thing. Obviously, they've permanently lost the capacity to breastfeed, and they've permanently lost the nerve connection between the nipple and her brain. There's a named nerve. It's called the fourth intercostal nerve, runs between the fourth and the fifth ribs on either side, that has a privileged path to the brain, privileged path to your hypothalamus, where it elicits the production of oxytocin. Nipple stimulation produces oxytocin, used to be called milk letdown factor, causes the breast to produce milk. Not only does that oxytocin cause the breast to produce milk, but it's also part of the unitive effects of the sexual embrace that unites husband and wife, right? That arousal is more than just, wow, this is great. There is a unitive effect of that. That is permanently lost. You can never get that back. Here is one of the advocates for that operation, an imbecile named Joanna Olson Kennedy. This is an article that she cites herself, as most arrogant people do. She cites herself in her testimony. She uses this as a reference. The Standards of Care uses this as a reference for chest reconstruction, again, the use of that term, and always a neologism. It's a sort of a mark of psychosis. The neologism this time is transmasculine minors. And what does she use to prove that this surgery works? She uses an unproven test instrument, a test instrument that involves quality of life survey that she herself created that is completely untested and unproven. And some of the questions were actually written by the children in her own clinic. An imbecile. Okay, so known harms I've already described to you. The proposing a surgical plan. When you talk to a patient or the parents of that patient to propose surgery, you have to present the evidence to them so that they can make an informed choice. If I do it this way, what's the likelihood of success? If I do it that way, what's the likelihood of success? When you have certainty of harm with every procedure and your level of evidence is only at the experimental level, then by definition, these are not surgeries that could ever be offered to a child. And I say that the patient is a child, and I say all of them because all of these patients are children, no matter how old they are. Yeah. Okay. So examination of benefit and risk and the likelihood of one outcome or another is based in levels of scientific certainty. And we're in the era now of evidence-based medicine. We're supposed to be working in that world of evidence-based medicine, and every specialty has crafted guidelines for what qualifies as evidence, right? This is the evidence that we use in the Association of Plastic Surgeons. What I would point out to you in this slide here is that at the bottom, lowest form of evidence is an expert opinion, right? Which is an interesting thing to hear from a guy who's offering you an expert opinion right now, right? But in order to offer a surgery as something other than experimental, you have to have level 3 evidence or better. So if you look on that graph, level 3 evidence or better, right? Which means that you've got case control studies. The American literature has no such evidence. None. There's none. All of that's being offered to children and adults is experimental surgery by definition. The weakest evidence supporting a right decision is the opinion of an expert. And of course, the attribution is to an unknown person, which is how things like this ought to be, right? Okay. So claiming a standard of care is a misrepresentation of facts, right? When you claim standard of care, what you're saying is that to do anything other than what I'm claiming is a standard of care is to risk harms to the patient, right? And that to do such a thing is evidence of an ethical or illegal violation. And it must be based in level 3 evidence or better, right? There has to be a validated test instrument by which preoperatively I can say, if we do it this way, that's the risk and that's the benefit. If we do it that way, that's the risk and that's the benefit. There is no validated test instrument in gender affirmation surgery, even for making the preoperative diagnosis, much less what the likely outcome is going to be, right? Guidelines, on the other hand, so standards of care is like do it this way or you're an idiot. Most medical surgical procedures, the patient and the parents are often guidelines, which are graded. You say, well, if we do a thyroidectomy, this is the likelihood of cure. If we do a lobectomy, this is the likelihood of cure. And what are the percentages? So it's a graded options of care. And into that enters the patient's particular needs. I can't possibly tolerate, a lobectomy because I can't stand the idea of having radiation therapy, whatever it may be. Okay. WPATH standards of care. They're claiming on the title page, this is a standard of care. Do it this way or bad things will happen. And within the first page of the text, it says flexibility. Oh, really? Flexibility. It's intended to be flexible. Diverse needs of the transgender, gender diverse globally, blah, 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 blah. So now they're saying, well, it's really more like a treatment guideline. The problem is that when these surgeries are proposed, they don't propose alternatives of care. So it's not a treatment guideline by definition. It's not a standard of care by definition. So they misrepresent the risk when they say, 40% likelihood of suicide, and they misrepresent the benefit when they say it's life-saving. This is fraudulent behavior. It's an intentional concealment of alternatives of care. Okay, so it's a fraudulent enterprise. It harms people 100% of the time. They're defrauding families and insurance companies, and they're using defective language and coding, deceptive coding that has to be investigated. And I understand the FTC is definitely jumping all over this. So essentially what you have is consent under duress. The patient, a family is being deceived in every way, and they're obtaining consent under duress, which is invalid. And by the way, if your claim is that you're doing the surgery to prevent suicide, by definition, a person who is suicidal is incompetent to give consent. Okay? Forgive me for running over, but behind all of this, we have to examine how academia was ideologically captured, how it produced other imbeciles like Jack Turbin, right? Yeah, how is that happening? How is it that every credentialing body, from teachers to nurses to doctors to lawyers, they're all singing from the same songbook, right? And that's what's destroying medical care and everything else. So known harms and consequent chronic wounds, and forgive me for running late. You have to understand that behind all of this is a spiritual wound. As I spoke about earlier, persons who seek surgery to change their appearance must be carefully examined for spiritual wounds. Believe it or not, understanding this issue is very important to the training of plastic surgeons, or at least it used to be. Body dysmorphic disorder is a psychopathology that frequently presents to the plastic surgeon. The patient has a profound sorrow that has its origin in a wounding event, typically in childhood, when they lack the capacity to understand what has happened to them. They do not want to examine that wound because it is a horror that they don't ever want to see again. And yet they feel the sorrow, they feel the weakness, the isolation, and they want an explanation for why they feel so bad. So they develop an aesthetic explanation. I'm alone and I'm sad because my face is ugly, because my nose is too big, because my breasts are too small. This aesthetic explanation is like a bandage that keeps the wound covered, and affirmation surgery is like adding layers to the bandage over the top of a seeping, stinking bandage that is already there. It looks clean and smells better for a while, and the child feels better for a while, but beneath it, the wound continues to fester as the sorrow and the isolation deepens. In the case of the gender discordant child, the content of the obsessive thought relates to their sexed appearance. It's just like all other forms of cosmetic surgery. It begins in the subjective life and is concluded in the subjective life. That's why they're always about quality of life surveys, no objective outcomes data, right? So affirmation care, including surgery, is nothing more than a professionally crafted obsessive compulsive process in the service of a performative identity. Social affirmation is like rehearsing for a play, including character names, mannerisms, movements, voicing, and the story itself. I've always known I was a boy, even when I was 3. The makeup, the wardrobe, all of it ordered to convincing your audience that you are who you pretend to be. It speaks of a struggle for authenticity, the way a theater actor might struggle to make a compelling character even while rehearsing poorly written dialogue. I was assigned King Duncan at birth, but I've always known I was Lady Macbeth. I call gender affirmation care the little theater from hell. When dialogue coaching, makeup, and costuming fails to move the audience to applause, then surgery is offered in order to finally kill King Duncan. The care of these children is a work of mercy. We are working in a broken and bewildering battlefield, seeking the wounded. The wounds which started in the soul are now visible in the wounded bodies. And I will finish now. There is a temptation to rage at the enemy, and I do it daily. But that rage availeth nothing. When the bullets are flying, it's better to be calm and composed. We must be like well-trained combat medics, moving with purpose through the chaos. And just like a well-trained medic, if we find a wounded enemy combatant, we must render aid to them as well. Family members who supported the transition, school teachers who made the referral, even bankrupt plastic surgeons who have lost everything in court can be seen as victims if we have mercy in our hearts. We are not in the service of a political position or our own favorite ideology. We're in the service of life in its fullness. We must be willing to offer ourselves unreservedly for those who are suffering. A life lived for the good of others is the true human identity that we are all called to. May God, who is rich in mercy, grant us the courage and the strength. Amen. Thank you.